Thanks, everyone. Sorry for the late start. Amy Waldman asked me to step in here today because she had to leave. So I will be try to fill the large shoes here. And since this is a relatively small group, we can also have an exchange. And I didn't know whether there would be patients and families here. Could I have a quick show of hands? Who's family and who's patient? Anybody? Probably online, their family. So this is geared more towards patient audience. I see a nice show of hands online. So nice to see that. So I will take you briefly through here's some quick disclosures and an introduction to myself. I'm a neurologist at Massachusetts General Hospital in Boston. And just by way of describing what I think is happening in our current landscape of genetics, as we are not only able to make more and more single gene diagnoses, but also have increasing access to genetic technologies and to industry partners that are willing to work with us to bring therapy to patients. This is becoming an interesting landscape that we're facing, and I see a lot of patients coming to us asking for treatments and treatment development, and I'm very lucky to have many partners who are working with us. This is a rapidly changing field, and I would just want to acknowledge that this takes a village. In the whole process, it's, I think, very important for us not to lose sight of patients and families. And here's one Alexander patient who was treated at our site and enrolled in one of the trials and has become close friends with my nurse practitioner's daughter. And I think the human dimension and the fact that we come together to build relationships and understand unmet need and leverage the biology in that context is absolutely key to moving forward, because there's so much uncertainty. And while there are great opportunities to transform and help people, there's also huge risk. And the only way to manage this is by building relationships. So just to introduce Alexander's disease, for those families who might be new to the field and looking for some orientation as to how this disease comes about and how we think of disease pathology. It's a single gene disorder caused by mutations in GFAP. Glial fibrillary acidic protein is encoded by this gene, and we have various phenotypes, meaning disease course can vary from infantile onset in the first 2 years of life, head enlargement, loss of early milestones, seizures, as opposed to later onset disease in juvenile patients who might have a more insidious onset with some speech abnormalities, headaches, complaints of emesis, vomiting. But in most of these cases, we do find MRI changes that are often pathognomonic for Alexander's disease and can help accelerate the path to diagnosis. As I said before, glial fibrillary acidic protein is mutated in this disorder, and the thought is that this alters the solubility of the protein, so that now in the astrocytes predominantly they accumulate as part of what we call Rosenthal fibers, which in some cases leads to swelling of different structures and has been misdiagnosed in the past as tumor formation and being biopsied, and we find these abnormalities. So just to highlight for families who are new to this disorder, this is an autosomal dominant disease. Just to give an example here, in this example, the father is affected, has one copy of the mutant gene and can pass that on to 50% of his offspring. The same could be true for the mother passing this on. And we find actually in a large proportion of patients that some of these mutations also arise sporadically or de novo, meaning they're not found in mother or father. The important distinction of an autosomal dominant disease is that you only need one affected copy of the gene for this to manifest. Albie Messing is the scientist who first discovered mutations in GFAP and has laid out a beautiful roadmap to charting and comparing mutations and finding genotype-phenotype correlation in this disorder, and really helped us understand whether there's certain mutations that are associated more with infantile onset disease versus juvenile onset disease, or associated with later phenotypes in adulthood. And Mass General, where we see patients all the way from childhood to adulthood, we are seeing more and more patients also presenting in adulthood with a more chronic and insidious course. And so the path to diagnosis is a difficult one in terms of not just making the diagnosis, but also then predicting disease course. It's important to keep in mind that there are also benign variants in GFAP, so not all variants that you find are necessarily disease-causing, and understanding how you can establish pathogenicity is often based on testing other family members and comparing with databases and collecting experiences, as Albie Messing has so nicely enabled over the years. So the classic Alexander's disease caused by mutations in GFAP manifests in the brain as a frontal predominant disorder in early childhood. This is a disease that you can tell by its frontal predilection, also a little swelling within the frontal parts of the brain, we think contributing to some of the macrocephaly, to the enlargement of the head. But it's important to keep in mind that this pattern is mostly associated with childhood onset disease, and in adulthood we can have other patterns that involve brainstem or cerebellum alone. We can also see some interesting distinct patterns of contrast enhancement. Since I see so many physicians in the room, I'm going to do a little more physician speak. So there can be garlands of contrast enhancement along the ventricular ependema. There can be contrast enhancement within the brainstem, and those are often giveaways for making the diagnosis of Alexander's disease. Common onset in the infantile form is in the first months of life. Seizures are a common manifestation, abnormal eye movements, nystagmus. You will often find this swelling within deep gray matter structures like the caudate. Often this will lead to biopsies if the genetic etiology is not fully understood. Many of these children develop something we call hydrocephalus, so ventricular enlargement. So increased intracranial pressure is certainly a contribution to early manifestations and symptoms. But despite shunt placements, as in this young child I saw years ago who was 4 months of age, seizures often are recalcitrant and continue. And generally, the earlier the onset of the disease, the more progressive the disorder. Juvenile Alexander's disease as I mentioned before, presenting later, ages 4 to 10 years of age, and slower in progression. Symptoms can include speech abnormalities, difficulty swallowing, frequent vomiting, increasing tightness in the legs, balance problems, seizures. They can also have enlarged heads, but not as consistently as in the early infantile form of disease. And we often will find breathing problems. So just to highlight for those families that might be facing some of these speech abnormalities in children, we often will distinguish different forms of speech abnormalities. You can have problems with articulation, expression. Many of these late onset patients actually have a lot of mumbling and say that their speech was always altered, always impaired, and never normal. It's always hard to understand them. This might be different from fluency disorders or word finding difficulties that are more localized to supratentorial regions, to parts of the brain that are involved in naming and word finding, as opposed to the articulation that is often a brainstem problem. Often going hand in hand with that are the symptoms of swallowing difficulties. This is actually a common complaint in patients with late onset Alexander's disease. They will often react to certain types of textures of food. They will have common complaints in early childhood of aspirations, but in the later forms of the disease, it will often continue, and they'll come to you saying that they always had difficulties with certain types of foods and seeking out ENT experts to help guide them. So speech and swallow experts are really integral part of the managing the disease. In adulthood, as I mentioned before, there can be a more chronic course here beyond the swallowing and the problems in slurred speech. You can see gait difficulties, dysautonomia that often will manifest. I had a patient as late as their 60s who was a physician at Mass General who came with a complaint that every time he was riding his bicycle, he had trouble maneuvering it into his garden, and the simple coordination difficulties that he was experiencing. He was a very astute man, led him to get an MRI and find a pattern of brainstem involvement, the latest onset patient with Alexander's disease I've encountered. So just an example here of a late onset Alexander's disease patient, 26-year-old engineer with reflux and bladder problems. 2 years later, he developed swallowing problems, particularly with fish and shellfish. His throat tightens up and he has spasms. His mother died at age 50, first balance problems in her early 20s, and speech and choking episodes. And so note here the contrast enhancement within the brainstem, which is a common finding in the late onset patients. And we've been seeing this again and again over the years. And we're trying to understand how much of a predictor it is of disease progression. Often there's a lot of involution of the brainstem and medulla, and often very thin spinal cords. So I think this is something that hopefully will also guide future treatments and understanding of disease progression. Just to highlight again, having a high clinical suspicion and recognizing MRI patterns can be extremely helpful to making the diagnosis in Alexander's disease, blood or cheek swab for genetic testing, and then really grappling with the mutation based on whether it is a known disease-causing pathogenic mutation or it's a novel mutation, and then testing other family members to understand whether there are manifestations of this new variant in the parents is often key, not only to understanding pathogenicity, but also genetic counseling of the patient themselves. So I think one topic that has come up again and again in Alexander's disease, and I just want to briefly highlight because it is also a topic within trial patients where we're administering intrathecal drug. Yes, there is increased intracranial pressure in Alexander's disease, but it's not increased intracranial pressure as we see in brain herniation, as shown here on the right, where time is of the essence and often surgical management is required. But it is often the kind of increased intracranial pressure that has to do with transient swelling of certain structures. And I think that the increased intracranial pressure is certainly something that is important during a certain phase of the disease, but will often not persist and doesn't really apply to the late onset forms the same way as it does to maybe the early childhood diseases. So I'm going to turn now to medical management and just emphasize that, as with other leukodystrophies, and just understanding how to avoid aspirations is tantamount. Lots of these genetic diseases suffer from complications that you can avoid if you are prudent about getting swallowing studies, making sure that G-tube is placed at the appropriate time before pneumonias or other complications occur. Prudent use of antibiotics, G-tube placement, as I mentioned before. I'm very fortunate to have Dr. Brian Wishart in my clinic, a physiatrist who guides me with antispasmodic treatment, pain medications, understanding how to manage orthopedic issues and bracing. We work closely with physical therapy, occupational therapy. Antiepileptics are tantamount, and we've been using valproic acid quite successfully for the emesis, thinking that that is probably the brainstem lesions might be responding to valproic acid here. Just some general recommendations around seizures and epilepsy, clearly understanding at which stage of seizure severity you are determines what you do. Not one size fits all. First, seizures can occur with fever, even in a normal population, so you want to be careful about escalating drug too fast. But then recurrent seizures does prompt not only repeat EEGs, but then often multiple drugs and referral to epilepsy. So again, I emphasize that every stage of a disease requires a different management, and you cannot extrapolate from an advanced patient what to do at an early stage, and that careful, nuanced guidance and understanding of risk stratification is a key to successful management. I think we also have a lot of resources for language and cognitive impairment, and understanding when neuropsych testing is appropriate and reasonable in the late onset forms of disease, but also understanding what communication devices might be available for early onset patients that still have some cognition and could learn how to use these. And we're fortunate not only to have physiatry, but also the Lurie Center for Autism close by that helps with those kinds of interventions. Just to mention that orthopedic disorders are frequent in children with leukodystrophies and also in Alexander's disease patients, where often scoliosis can occur and curvatures in the spine that are causing pain and causing further complications and predilection to fractures. So understanding pain in nonverbal children is a key component of what we do when we are managing early onset infantile or juvenile disease and Alexander's disease, because you have to here really be vigilant and screen multiple different domains and understand how to then apply recommendations for pain, not just with medications, but also understanding alternative treatments and management that might have to do with positioning or ability to relieve spasticity in other ways. So just briefly to turn now to approaches to gene therapy, I think it's an exciting time for many of the leukodystrophies where we're thinking about in vivo gene therapy and ex vivo gene therapy for disorders that are autosomal recessive in nature and require gene addition. But these viral vector delivered therapies can also enable tackling of gain of function mutations, and we are seeing some of this occur in other neurodegenerative diseases such as Huntington's disease. And we're fortunate that we have a first antisense oligonucleotide trial in Alexander's disease. Just to for the families briefly highlight the in vivo gene therapy and ex vivo gene therapy are reliant on viral vectors that deliver a corrected gene either directly or indirectly to affected cells, whereas antisense oligos are short sequences of oligonucleotides that interfere with not the DNA level but the RNA level, and so this has become transformative for many single gene disorders where we are now starting to understand that we can interfere with the RNA and either avoid binding or have other ways of influencing splicing or degradation of RNA. So just to highlight that again, Albie Messing has laid the groundwork here for developing antisense oligonucleotides that are delivered intrathecally for Alexander's disease. And he was able to show proof of concept of this in a mouse model of Alexander's disease and then a rat model that more recently. And this is based on the thinking that you can silence GFAP postnatally, so after the development of the nervous system, and this has an important impact upon formation of Rosenthal fibers, and he was able to show that in the mouse model he could prevent formation of Rosenthal fibers. This has led to a trial that we're currently part of that is sponsored by Ionis and is a placebo-controlled trial and blinded, so I don't have results, but I'm really looking forward to finding out over time whether lowering of GFAP can happen in the pertinent compartment of the nervous system through this targeted intrathecal delivery, and whether that lowering of the GFAP could also lead to clinical improvement. And that has to be evaluated for each phenotype, for infantile and juvenile late onset patients separately. And it can be tricky because disease course varies between these phenotypes. But given the progressive nature of the disease, I think we're going to have answers due to the placebo-controlled nature of this trial. So just to highlight that we have an obligation here to monitor and manage treatment complications and all these opportunities to transform disease through targeted genetic therapies. It comes with challenges, whether it's in ex vivo gene therapy, understanding some of the impact upon bone marrow health and the occurrence of insertional mutagenesis, or with in vivo AAV treatment where we see complement activation, impact upon liver inflammation, but also in the intrathecal trials, there are risks that we are just learning about, while these are more short-term, clearly trying to avoid post-LP headaches, as well as any complications from increased intracranial pressure. is key. And so we have a first fellowship that is starting to train residents or young investigators coming out of residency who want to step into the field of gene therapy to help design trials, but also more importantly, implement and counsel as to risk benefit. And we're going to, over time, really need a huge amount of people if we want to bring these treatments to patients and families over time. So it's the right time to start thinking about education here. Good. I think my last slide here is just to acknowledge that it really takes a village, and I see myself as really part of the larger ecosystem in Massachusetts, where we're learning from so many people how to start trials and implement them, and many of the coordinators who really do the work in the trenches to bring these treatments about, and the physiatrists and colleagues from other disciplines who've helped us bring trials about and even got to some FDA-approved therapies. So want to thank everybody and open this up a little bit for questions. Thank you. Glad to take questions online as well.
Thank you so much. I have one question. I'm at Lurie Children's in downtown Chicago, so we have a very much multicultural, Chicago is so diverse. And so Rick, I didn't know if you have any tools for patients and families of other cultures and the health literacy piece of it's so complicated to explain gene therapy, not only for the professionals here but to patients of other countries and cultures with language issues as well.
No, thank you for that. I think that's such an important reminder that we have to always address diversity on many levels, right? And I do worry a lot about us, embarking on boutique medicine here, as often the people who are being diagnosed are those who have genetic literacy and are the ones who need to pass that gate to even get to therapy. And so how do we build structures that allow for equal access? I think it's hard, but I think ASGCT is a great place where a lot of this thinking is happening. It's the American Society for Gene Cell Therapy, who then over the past few years have really been pioneering and creating more material for patients and families and thinking about access for gene therapy. So in trials, I think the access issue is a little easier, and I worry a little bit once we get FDA approval and commercialization sets in. There's also socioeconomic differences that are then occurring, and a lot of the international patients that we treated in trials are not getting access to those therapies anymore. So I don't have easy answers, but I think it's a very important issue, and I think the right place for this is to go to ASGCT and then help that be then further disseminated across the American College of Medical Genetics and then AAN, CNS. I think all of those societies can play a key role here. Guangping, when are you going to come up with a gene therapy for Alexander's?
Yeah, I think at this point we start much later than the ASO, but making progress. We start saying initially correct Rosenthal fiber in mouse model. Unfortunately, the mouse model does not have any clinical phenotype. But now we move into rat model. Now we start seeing very encouraging results.
That's exciting.
Yeah.
Great. No, it's great to have options.
Yeah.
And I think are we going to have proof of concept through Ionis and the antisense oligo trial, and will that over time, lead us to understand, thresholds of mutant GFAP that we need to correct, and understanding, where and at what disease stage, and that will hopefully lead to more permanent solutions over time.
Absolutely correct.
Yeah.
Thank you.
You. I was wondering if you could talk more about the ASO clinical trial. How often do patients have to get dosed with ASOs? And is it like, do they have a port for intrathecal administration? And you probably can't talk about the results because you said you were blinded. But are you hopeful that this is a potential long-term therapeutic for Alexander's disease?
Yeah, I think there's, based on all the preclinical work and also the fact that this administration is quite feasible, I'm very hopeful that we're going to arrive at something that is, going to be have traction and be able to be implemented in the clinical setting. It's really too early to say, and but we do have some representatives from Ionis here. So if you want to talk about future timelines and what to expect in terms of readout over time, I'm not going to volunteer you, but intrathecal administration is something that can be done by neurologists, nurse practitioners. It doesn't require brain surgery. There's a certain ease of access. It's not as easy as taking oral medication, but it is something that is tolerated. I think in terms of understanding of feasibility, in younger children, clearly we need anesthesia, and repeat sedations over time are always a concern. But if it's well tolerated by the child, there's no reason not to proceed. You want to say something to how excited you are? Yeah. Do you have a sense of timeline, when you might have first readout, or you might be going to FDA, or you don't have, we won't hold you to anything, but.
Yeah, no, I mean, I think because of the way the trial's being done, they're looking at safety cut points, and it's going to be all based on that. So giving you a timeline is really not fair. I don't want to give a timeline to a family and then be like, you said at this meeting. So, we don't really have one at this point. Sorry. Not what you wanted.
I tried.
I know.
Good. I see there are some questions in the chat. I don't know if you. Go ahead.
Yeah. I just have like a lot of naive questions, as ASOs is not my field of study, but I'm very interested in it. Has there been any research showing that ASOs can cross the blood-brain barrier, so you could do a more easier, like systemic delivery route, or is it more of that you have to deliver it into the CSF to get a better, not transduction, but infiltration into the brain?
So I think it's pretty well established that you need to deliver this into CSF. I mean, if you were to give it systemically, you're inviting all sorts of other organ involvement and other off-target effects that you don't want to have happen. I think the fact that you can deliver into that targeted compartment is an opportunity here, and it's certainly something that we. Multiple diseases and trials have now established. So sorry, I'm trying to get into the chat here, but oh, I see what's happening. You cannot. I see. Maybe it's left over from before.
Yeah, that was from the previous session.
Oh, I see. That's from the previous. Okay.
And Dr.
Good.
asking if this was the Alexander disease session.
Okay.
Yeah.
Brian.
Is there any thought or discussion about potential administration via like an intrathecal pump to not have to be coming in frequently and have more consistent administration?
I mean, it's not
Not yet.
the trial, 'cause it's
Yeah, no, not for the trial.
that, but there's lots of different things to look at.
Yeah. You know, in the SMA field where there's far longer experience, there have been individual patients who, because of the difficulty in accessing intrathecal space, where the individual physician has opted for, you know, a port that has been placed and that allows for easier access over time. It's not quite the same, I think, as a pump, but you know, I think there are probably individual solutions where there's scoliosis or, you know, some difficulty in access. Yeah, good point. Yeah.
Oh, yeah, I just said that we wouldn't, that nothing would change during the trial. Obviously, it would just be that, but it may be something in the future that people will look at.
Great. I think if there are no further questions, we'll close this session, and I'm available and glad to answer anything in the break. Thank you.